This is Dr. Tiwari.
And this is Dr. Kocak.
And you're listening to the
Best Podcast Ever.
Broadcasting from Columbus, Ohio, we'll be talking about plastic surgery procedures focusing on only the breast.
Ranging from breast reconstruction to breast enhancement and reduction, we'll cover everything you ever wanted to know about the breast.
All right. Good morning, everybody. Here we are in Columbus, Ohio. Thanks for tuning in to the Best Podcast Ever. We are super excited today. We have a very, very special guest here. Dr. Kocak and I are very excited to have Terri Coutee, the founder of Deep Sea Journey, on our podcast. Welcome, Terri.
Thank you. Thanks for having me today, you guys. This is a great new podcast that I'm happy to be part of.
Where are you coming to us from, Terri?
Seattle, Washington.
Ooh, wow. We've crossed the country. This is kind of cool.
Yeah. Yes. That's what I like about it. Yeah.
So Terri actually is a very interesting person, and we're very excited to actually know her and have met her. She has a great story, and I'm not going to tell it for her. I'm going to give her the opportunity here to do it. But why don't you tell us a little bit about your story, Terri, and the organization and foundation that you ultimately ended up putting together?
Yeah, life leads you in ways that you have no idea where they are going to go. And that's exactly what happened to me after being diagnosed with breast cancer twice. First time was in January of 2002. Second time was in April of 2014. First time, standard of care at MD Anderson, where I was treated at the time, was lumpectomy. I had to have two, didn't get clear margins. Radiation. Before that was 18 weeks of FAC chemo, fluorouracil, adriamycin, and Cytoxan. 6 weeks of radiation after that.
Now, this is all the way out in Houston?
Correct.
And you were still living in Seattle when you went and did this, or where were you living at that time?
No, we were actually living north of Houston in a town called the Woodlands. So, drove into MD Anderson for my treatments. And then I did the standard of care, which was 5 years of tamoxifen. Humming along, got my strength back, went back to the gym, went back to work. And then we moved to Tucson, Arizona. And that's where I had my second diagnosis. We've moved around a bit. It's my husband's job. So I had my second diagnosis. I had a recurrence and I had a new primary. So I felt pretty sure I was going to have a double mastectomy, but I had a really well-informed, well-connected breast surgeon, thankfully, who said, I'm not going to do a double mastectomy until we verify it through scans and some more testing. As it turned out, I did have to have a double mastectomy. She actually did a skin-sparing, nipple-sparing mastectomy because the day we talked about, whether I was going to have a mastectomy or not, I didn't go in there prepared to talk about breast reconstruction. That was not even on my radar.
And what year was this, Terri?
2014.
Okay, so this was before people were even doing nipple-sparing mastectomy to the degree that we see it today.
Yeah. She was really a well-trained breast surgeon. And she told me up front, she said, hey, because of your tumor size and location, I'm pretty sure I can do a skin-sparing, nipple-sparing mastectomy. The reason she did do that, Dr. Tiwari, is because she gave me all of my options for breast reconstruction. Implant-based, Diep Flap. But for me, my personal choice, we had a shared decision-making conversation. I told her I wanted to use my own tissue. I didn't want anything foreign in my body. That was my personal choice. Not everybody makes that decision.
Can we, what I'd love to do is I'd love to flush that out for you. Why was that so important for you back then?
I've always been, I think, to answer your question, a bit of a purist, I call it. I try to eat healthy. I try to avoid anything that is, to me, an implant was foreign, to be quite honest. When she said I could use my own tissue, I'm like, wow, that seemed like my lifestyle. Now, I had to do a lot of research into that because, you have a hip bone to hip bone scar. implants, at the outset.
You had a DIEP flap.
That is correct. I had a Diep Flap breast reconstruction. So
just for people listening, what is that?
Diep Flap it stands for deep inferior epigastric perforator. So rather than using an implant to reconstruct your breast, you use your own tissue and you use the tummy tissue. So it's a bit of an elliptical shape. There are many parts of the body I've learned since my patient advocacy that you can use, but the Diep Flap uses the tummy tissue. And it takes the perforators, which are the blood vessels underneath the skin of the belly, and people like you guys who are, amazing at this and have done so many, tease out those perforators from the tummy area without sacrificing the rectus abdominis muscle. And those are then disconnected and they're transplanted to the breast area. Those blood vessels then are reattached to a blood vessel in the breast area. And then what you end up with is soft, warm, breast-like tissue. I consider it my own breast now, even though my breasts were removed with mastectomy. It's your own breast tissue.
That's a strong statement to say that you'd consider it to be basically like your breast tissue. That's actually fascinating.
Yes, because what I've learned from you guys is the tummy tissue, you guys meaning plastic surgeons in general, microsurgeons in general, the tummy tissue is very similar to the breast tissue, correct?
It can be, yeah. I mean, a lot of times the breast has breast tissue, but around it is typically a variable amounts of fat, and the tummy tissue is basically adipose tissue and skin. So it can be very similar, yes.
Yeah, so I might segue into a question for you guys that I get a lot from patients because it is a lot of fatty tissue in the tummy area. A lot of patients that are considering Diep Flap, they're concerned that there could be a reoccurrence from the tissue that is transferred from the tummy.
Yeah, that's...
Now, I know differently, but I'd really love for you guys to answer that.
Well, I can comment on this, Dr. Tiwari, if you want. It's basically, it's an interesting thought because it is tissue and it's a different tissue though. Breast tissue, the cancers that occur in the breast are usually in the breast tissue itself. And so that tumor is happening specifically in the breast tissue, which is separate and different from the fat tissue or the subcutaneous fat. The tissue that comes from the abdomen doesn't have any breast tissue, so you can't get breast cancer in that tissue. Now, after a mastectomy, it's technically possible that there's still a little bit of breast tissue left behind. So a local recurrence could happen. And there's a very small rate after mastectomy because a mastectomy is largely curative, but it really is mostly a risk reducing operation because it takes out most, but usually not all of the breast tissue.
I love that word, risk reducing. That's exactly what it is. No 100% with any type of surgery that is performed anywhere, really. So,
but with your Diep Flap, then, so this is in 2014. You're living in Arizona, and you ended up back in Texas for your Diep Flap. Is that true?
That is correct, and it was the criterion that I laid out for myself, if you will, about what I wanted in a microsurgeon, because I started doing the research. How many have they done? What is their success rate? How many of their flaps actually survive? How many surgeons are in the that was an important criterion too.
Terri, we lost you for just 1 second there, but can you tell us again how many surgeons is that in the operating room? Is that what you were about to say?
Yes.
Okay.
Yes. How many surgeons are in the OR? In other words, is there two microsurgeons in there? Is there a microsurgeon and a PA? Is there a microsurgeon and a resident? Those are all questions I feel like, patients need to be asking because it varies across the country depending on where you go. The group in Arizona at the time, one microsurgeon and a PA, honestly, you have to have kind of a connection to the plastic surgeon. that wasn't aligning for me perfectly. And I knew this was a life-changing surgery. So I started looking around. I looked all over the country. And at the time, my choice was to go to San Antonio for my reconstruction.
To be fair, we had just opened our doors, so we're not gonna blame you for this one. We had just started.
I know.
2014. We'll let you slide. But it sounds like you found, and we know the people you found. You found an amazing group. You found the PRMA group. Our colleagues out there that we know very, very well. We're very lucky to have them as colleagues. And that's what's fascinating is that you did all this research. You found this group, and then you decided to travel really far away from home for an operation that is pretty complex. Tell us about that, because I think that's one of the most fascinating things about your story. And I think a lot of patients who find our groups, like PRMA, like our group, like some of the other higher volume groups, I think one of the biggest concerns for those patients is, how am I going to travel? Does it work? Can you tell us about that?
Yes, that's a very good question. And thanks for asking it. It takes planning. And this is part of the reason I opened my foundation. After I started writing a blog, I opened a foundation so that I can push all of this research that I did and share it with other women and men who are going through reconstruction, because it's not just about finding a plastic surgeon. I want to circle back to your comment too in a minute about you guys not being open. I've learned so much in the 5 years I've been doing this. I want to circle back to that. It's not just about finding a plastic surgeon. It's about, I'm going to fly for this surgery. How you come home with drains maybe and scars and incisions. How is that flying? Women want to know about that. Gosh, how long do I have to stay if I'm going to go out of town? That can vary from surgeon to surgeon. Where am I going to stay? Do I have to bring somebody with me? All those questions come up. But I have to tell you, Dr. Kocak and Dr. Tiwari, really feel fortunate to have met you guys. Here's the thing. When I started my platform, I knew about one group. I knew about the group that I went to. And I know you guys know them. Your colleagues, you all share information. But through my foundation, I was just talking to this actually yesterday to a resident. Through my foundation, I am so fortunate because I've had support to be able to travel to conferences and talk to plastic surgeons, talk to microsurgeons. So when I have my board meetings and they say, well, who are these people and how are you going to align with them? Let's talk about that. What's important to you? So there's really 3 criterion. One, I get to meet you guys. We've all met at conferences. I've talked to you. I've talked to you about your success rate. Secondly, I get to talk to your colleagues. The colleagues you speak of speak very highly of you guys. That's a bonus. Yeah, that's a bonus for me, though. And third, I always tell patients this, and I tell doctors too, where the rubber hits the road for me is if I talk to patients that have gone to these individual surgeons. So now I don't just know one surgical group that I can refer patients to, through my Facebook group that you guys are on. They might say, well, I live in Kentucky and I'm looking for a plastic surgeon. Well, guess who I'm going to send them to? I look geographically. Yes, Dr. Kocak, I'm going to send them to Columbus. I look geographically at where these women are located. And I go, all right, I know a good group. They're close by. They have a high success rate. Somebody looks at me and says, I live in Phoenix. I've met a microsurgeon at a conference. I can send you to him. He's well trained, high success rate, and I know patients that have been to him. So putting all egos aside, putting all preferences aside, I feel so privileged to have both sides to talk to, both the surgeons and the patients. And I wouldn't be talking to you guys today if I hadn't met you and value what you do and know that you're also helping with what I do is educating patients. So,
you have such a unique experience from what you've done and your own patient experience, talk a little bit about what it was like traveling for surgery for you, the recovery process, how long you were recovering before you came back home. Because, we see a lot of patients who drive to us or fly to us. And I think it's always a overwhelming thing for patients to think about traveling for a big surgery like this. So I think hearing your perspective for patients, whether they're driving or flying to us, is really important.
Right. So I think one of the things you have to realize is that the surgery will be paid for by insurance because of the Women's Health Care Act in 1998 that was passed. So the surgery will be paid for by insurance. However, travel, whether it's a rental car, whether you're driving, airline tickets, hotel or Airbnb, and your food, that all is covered by the patient. So there's two things I would say about that. It's going to be a financial sacrifice for some more than others, I guess I should say. I mean, my husband and I just kind of said, okay, well, we're going to bite the bullet this year. We're going to cut back on some things, and we're going to bring you back to health. We're going to get your breast reconstructed. That's a decision you have to make. But secondly, I always tell patients you've got to save receipts from travel that would include airline tickets, car rental, and lodging. You can't take food. But now I don't know if it's changed. Dr. Kocak is looking at me like, this is interesting.
This is unique. This is fascinating.
Our accountant said, save all those receipts because you can take them as a medical tax deduction. Now, I know that there are nuances to that in the amount that you collect, but either way, save them because you don't know that could go toward your medical tax deduction for that year. So there's that financial element. Well, then, okay, how long do I have to stay there? Where am I going to stay? A lot of facilities they'll be contracted with hotels through the hospital or even through their practice that have reduced lodging rates. So I tell women, to check into those. And they're used to catering to patients. They see patients come through their doors. So a lot of times they might even have a recliner that they will put into your room that you can use during recovery. Because if you have Diep Flap, in particular, you want to stay in that beach chair position so that you don't put too much tension on your incisions. Having a recliner in your room is nice. If not, ask for extra pillows. You normally, and I'm assuming it's the same with you guys, after the surgery, you stay there around 2 weeks. Now, that's changed since I had my surgery because at the time I had it, they were not using the ERAS protocol. ERAS is Enhanced Recovery After Surgery. So what that does, it gets patients out of hospital quicker, recovery is quicker, you're eating food faster, you're getting your system back up running quicker. So now I think patients are getting, if they go out of town for their reconstruction, around 10 days. I was in hospital for 4 or 5 days because I was an out-of-state patient. Now, even out-of-state patients are staying a couple of days in the hospital, 2 or 3, and then they're out for recovery. Then you have to schedule a follow-up appointment with your surgeon to check drains, check incisions. So about 10 days now, I would say, for many surgical centers, even if you travel from out of state. And then what's the flight home like? Well, I personally tell women they may not need it, but I personally tell them on your way home, secure a wheelchair through the airline.
Now, did you have drains when you were traveling back home, or were you already drain free?
I was drain free.
There you go.
And in fact, I remember going for my post-op, and I was getting my drains out really quickly. I know it varies from patient to patient, but I remember my surgeon jokingly calling me an overachiever. and I only think he did that because it's like, I think he was like happy that I wasn't going to have to fly home with drains. But patients do. And securing that wheelchair, to add to that, for airlines, what that does is it puts you at the front of the plane. You get on first, you get off first. And so if you have drains, if you're feeling a little weak or like you don't want to walk a lot, you
certainly can't be handling a carry-on at that point, because we don't want you lifting still anything a lot more than 10 pounds for several weeks.
Exactly. So I tell patients, have somebody fly home with you. And I let the stewardesses know. I said, I just had surgery. I can't lift anything. And they were so happy to help me out. But I only carried a purse on. I only carried a lightweight purse just with some very minimal essentials, a snack bar, some lip balm, make sure you're staying hydrated and wearing your compression socks home. You just had surgery. So.
And after you got home, was there any concern, or did you have a plan in place for how you would handle any delayed complications? It sounds like you didn't really have any, but did you have a plan in place, and what did you do for that?
Yeah, that's really a good question. I actually did. So before I left, I talked to my breast surgeon, and they knew she knew I was going to have Diep Flap and I was leaving. And I said, what if I come home with drains? I said, would you guys be willing to take him out? They paused a little bit. It's two different entities, but they agreed. They said, if you come home with drains, we'll be happy to take him out for you. Now I tell women, I had no wound complications. I didn't have complications when I came home. Felt very fortunate. But I was a compliant patient too. And I think it was part of just my personal healing ability, because everybody's different. We all go in with different scenarios. And I also think I was a compliant patient, even though I'm a middle child and I'm a really kind of ornery sometimes. When it comes to patient compliance, I was a compliant patient. So
I'm curious about one thing about your timing. I just as we talk about it more. So your breast surgeon was in Arizona, right?
Correct.
And yeah. So did you have your mastectomies and then travel to have your reconstruction? What was the time frame of these things?
Yes, I had my double mastectomy in mid-May. Then I started doing all my research. Where am I going to go for my surgery? I looked all over the country.
So no reconstruction at that time?
None. No.
And they did nipple-sparing mastectomy. So you had sort of all the skin on the outside of the breast still preserved, but no reconstruction, no implant, no tissue expander.
That is correct. No tissue expander. And I found out I was node negative, just like I was the first time. So I did not need radiation. But my breast surgeon, I have to say, was very good. About 4 weeks, I'd say, after my double mastectomy, she was very good about getting a physical therapist on board. Mm-hmm. So what that physical therapist did was teach me, because I didn't have a tissue expander, I think in part, she taught me to kind of massage skin and pull it up and away from my chest wall so it didn't adhere to my chest wall in preparation for my Diep. So May 2014 was my Diep. December 2014 was my, I'm sorry.
Yeah, your mastectomies in May. And then reconstruction was December?
Correct.
So you took,
so about 7 months.
You really took this experience, which, by really any stretch is a very difficult, experience to go through. And you've transformed this like a beautiful butterfly into the DiepCFoundation. So tell us how that happened and how you now take your experiences and use it to educate patients and sort of bridge this gap between surgeons and patients. Because I think that's something that we're trying to figure out with this podcast is how do you bridge that gap between the patient and the surgeon? And I think one reason why we're so, fond of you is you've really done it. You've bridged that gap, in a way that almost nobody else has.
Oh, very nice words. Thank you very much for that, Dr. Tiwari. I feel so fortunate. I have nothing to say, but this was pure fortune for me. And if I didn't take this opportunity and give back to others, I'd be missing the boat for why I'm placed on this earth, I think. But I have to tell you at the outset, I thought my husband was going to boot me out the door because at the time I was in the middle of my master's program in education. So I've been an educator all my life. And when I told him, I said, I don't think this is what I'm supposed to be doing anymore. I think I'm supposed to be educating women about this process. That didn't go over well because I'd already invested some money in my master's program. But actually, that to me was almost a structure or platform for me to be doing what I am now. I know that people say,
I mean, you're certainly educating people now.
Exactly. And so I guess my fortune is I have the time and inclination. And to your point, Dr. Tiwari, I think there's women, they don't have the time. They don't have the time, or they don't know where to look. This is where I've been fortunate to be able to connect with the plastic surgery community and the patients both to be able to provide, evidence-based information for them that they can actually use when they're planning their surgery. So to do it, it's something I really deeply believe in. And
you must get like hundreds of inquiries every month, if not more, I'm sure. How do you manage all that? How do you manage, you're kind of, a one-woman show to some extent. I know you've got people helping you, but how do you manage all this flow of information and questions and trying to stay true to your mission and also being kind of evidence and scientifically based? I mean, to be honest, it would be overwhelming for me.
Well, it's overwhelming for me some days too. And I think what I have come to over the last few years is that I can't help everyone. There have been instances where I may have connected patient to plastic surgeon and it just didn't work out. Well, that happened in my teaching career. There were parents that chose me as a teacher thinking I was the best teacher. And then they got into the classroom and things didn't work out. It's the same way. I've learned this over the years. I want everybody to have the best care. I want them to go to the best doctor. And we're all human. Sometimes, for whatever reason, personalities don't work out, or, well, gosh, that's not how I expected things to turn out. So I don't like what you told me. It happens. It happens. I think it probably happens to you guys too. It's just the reality of life. So how I manage it, I get up every morning. I open my social media accounts. I try to focus on my Facebook page because that's where all the questions come from. I get private messages on Twitter. I get private messages from patients on Facebook and Instagram, and they're asking questions. So social media has been my platform to reach out, and that's really how I communicate with patients. But I have to temper it too with my own life. At some point during the day, I stop and shut it down and I move on with what I do in my own life too. But this is the focus of what I'm doing right now. This is my work.
It's amazing. I mean, it's really amazing, I think, what you've done, but also how social media, for all its ills, how I think it's opened up these lines of communication in a way that we've never really seen before. So what do you see happening with shared decision making and this social media approach moving forward? How can patients best use it? How can we as surgeons, best use it so that we can use these platforms to come to a common understanding of how to move things forward for patient care?
Yeah, I think we have to be very realistic. First, we have to start with the education. Shared decision making is when a patient brings what they know to the table, presents it in their initial consult with whichever plastic surgeon they choose, and then you guys listen. Whoever talks first, you're both listening to each other. You're taking the information and the expertise that you have as plastic surgeons and combining it with what the patient brings. Now, you guys always have set information that you have. You have your skill level. You know what your process is. For the patient, that looks a little different. There are patients that come in and they want to take control of the situation. They want to be 100% part of it. They want to know that the what they brought to the table, the resources, the research, everything they brought to the table is going to be listened to and appreciated. But then there are other patients that come in and maybe they haven't done as much research. Maybe they didn't want to. And they come in and they say, I trust what you're telling me. That's shared decision making too. It kind of comes in a spectrum, I would say, for patients. For you guys, you have your expertise that you can share with your patients. But then what you have to do is tailor it to each patient. How much of this do I use from what the patient brings in? Is it all a ton of information, or is it just, I'm coming in here trusting you guys completely? That's tricky business for you guys to.
Yeah, it's funny. I always kind of think about, what do we as plastic surgeons have to do? We kind of very quickly, like in the first minute or so, need to assess the person in front of us, get a sense of where they're coming from, and it's difficult. I think that's maybe the hardest part of, just like meeting anybody new for the first time. You've got to kind of figure out the relationship pretty quickly. And on top of that, people are relying on your decision making. So it's tough, which is why social media, I think, is so great, because it helps us get insight into what our patients are thinking.
Yeah, and I think with social media too, I always tell patients, dip your toe in the water, whether you're on Twitter, Instagram. I think particularly Facebook for patients. They do a lot of online chatting and sharing on Facebook. That seems to be the most popular platform.
Do you see that changing over time? Do you see patients moving more towards Twitter or Instagram or Snapchat or things like that?
From what I've seen at the moment, no. Facebook seems to be solid for a bit of time. And there are groups that are going to fit your comfort zone. And there's those that are like, okay, this isn't working for me. Well, then leave the group. Try another one. Because there's many out there right now. I feel pretty fortunate in my group that I welcome with open arms having surgeons on the page, having radiologists on the page, tattoo artists, healthcare providers, basically. I want them on there. It gives the site credibility and it gives me a chance. I don't like to do it often. You guys have crazy schedules. You're so busy. But I like to tag you once in a while when I can't answer a question. Dr. Tiwari, you did it just last week. It was beautiful. I reached out to you. I had a question I didn't know how to answer. Boom. You answered it for us. It was great.
Well, we find, what you're doing, I think, is amazing. And I think it's a real kind of credit to how much effort you've put in to this over the last 5-6 years. Thank you for everything that you do. In the last couple of moments here, let everybody know where they can find you.
Okay. So the main page is DiepCFoundation.org. On there, there's the YouTube channel. There's all the videos. I write a blog, DiepCJourney.com. The Facebook page is Deep Sea Journey, Breast Reconstruction After Mastectomy. I have a public Facebook page that's under Deep Sea Foundation. YouTube channel, Deep Sea Foundation. That's spelled DIEPC, the first initial of my last name. And you can take it from there.
Well, we really appreciate you taking the time today, Terri. And we're going to throw some links on the podcast so people can get to those sites. And we hope we can round up again soon and talk more. I'm sure we'll have a lot more to talk about. So thanks for the time.
Thank you guys so much for having me.
Take care.
Bye, Terri.
All right, bye.
Thanks for listening.
We hope you found this episode helpful.
Want more info? Connect with us at mwbreast.com.
And go behind the scenes with us on Instagram at mwbreast. Thanks for tuning in.
And join us next week.